Good morning, everyone. Welcome to another PACOP Morning Tea Talk. My name is Caitlin. I am the Improvement Facilitator up here in sunny Queensland. And with me today...
my name is Natalie.
Wonderful.
And I'm in usually sunny Perth, but not today. It's a little bit rainy. And I'm the Improvement Facilitator for Western Australia.
Yes. So before we start, everyone, I just want to... pay respect and acknowledge the traditional owners of the land that we are meeting you from today. I am in Brisbane on the lands of the Turrbal and Yagara people, and Nat, you are...
Whadjuk Noongar people.
Wonderful. So we'd just like to pay respect and acknowledge those people and elders past, present and emerging who might be with us today or listening to this and watching this in the future. So today we are going to go through the SAS and the Symptom Assessment Scale, which is a considerable part of our PACOP program. And we know that like you see here in front of you, residential aged care, a huge number of people are dying in aged care around the country. And the SAS is a key part of our, or all of the program really, isn't it, Nat?
Yeah, so we have 5 assessments in PACOP, as you probably all know. And the SAS is the one that is resident rated. And that's the one we want to talk about today. And actually, that's the one we really, really love.
So you can see here what I'm showing now is part A of our profile collection, but also the SAS is also here in the deteriorating resident tool. The symptom assessment scale is just this tool here with the faces, and it assesses residents' distress, basically, about a set of symptoms. So, Nat, how do we really use the SAS and what do those symptoms look like? Can you talk us through that?
Yeah, so I suppose the first thing to really note about the SAS is it's our only resident rated tool. But of course, having a resident rated tool in our suite of assessment, it is what gives us that holistic approach to assessment and therefore response, so we can sort of meet the needs of the residents coming from all angles. So with that as the background, it's a hugely important tool because it is our chance to find out what's going on in the resident's head. And as Caitlin said, it's a distress rated tool. So by distressed, we mean anything that is of concern, worries, we like to use the word bother, to the resident. So anything at all that is bothering the resident, this is our tool to find out about it. There is 7 symptoms listed, defined in the SAS, and these are the 7 most common symptoms or problems experienced by people receiving palliative care. And we also have the option for other. And other, we'll talk about that as we go along this morning, but other really is any other symptom that's not listed.
And when we say distress scale, it's a scale from 0 to 10. So 0 being no distress at all and 10 being worst possible distress. And Nat, do you want to talk us through maybe how the SAS plays a part in like the profile, the deteriorating resident tool and outcomes, and how it's slightly different in each of those parts, or what the key element is in each of those assessments?
Yeah, so I mean, I suppose it is the same in all of our outcomes, whether it's profile or outcomes. It's the same tool. It's, you know, it's validated for use in palliative care population, which is why we've included it. And the way you use it is the same in all collections. However, of course, when you're in the profile collection, for instance, you are collecting that once every 3 months. The deteriorating resident tool, of course, by nature of the tool itself, is you are concerned about the resident, you think there may be something happening or the resident's not by themselves. So it becomes, again, hugely important again in that space because you're trying to get to the bottom of what is going on with the resident, which, of course, is why you've picked up the deteriorating resident tool to start with. And then, of course, like I said, once again, it's used the same, but in the outcomes collection, they're being asked about their distress scores on a daily basis. And of course, this is because we've already identified that they're palliative. So, of course, it's hugely important that we are asking them regularly and daily, how are you going? What is upsetting you? What's distressing you? So, of course, we can act on that and respond to that.
And I think it's also really key to know that that's our first assessment in the suite of assessments, because it creates that pause point and steers us right to the resident to be able to almost put aside our clinical concerns for the time being and actually just talk to the resident and work out where they're at and what's most concerning for them. And I suppose that leads us into our next sort of piece and our next question about why resident rated measures are really important in aged care and how that's come to be. Nat, can you speak to that?
Yeah, so resident rated is hugely important in aged care. I mean, resident in any health setting, the patient experience and the patient distress is hugely important. But specifically for what we're talking about today, which is residential aged care, is that often residents don't actually have a voice. And it's not because anyone set out for them not to have a voice. It's because, they are an older and more frail population, and they tend to sit back and often not be sort of assertive in letting people know what is worrying them. And we also there is like, this is anecdotally, but generationally, people often don't want to be a bother. Older people don't want to be a bother, and they already feel like, they can feel like they are a bit of a burden, and that is absolutely what they're not, and what we're trying to empower them with the SAS, really, to tell us. We're sort of inviting them to tell us what is bothering them, because at the end of the day, they are the person that we are trying to look after. So therefore, they are the most important person in the equation.
Yeah, and also, just formalizing that as well and being able to capture that regularly, whether that be, oh, bless you, regularly, whether that be through the profile every 3 months, the deteriorating resident tool whenever you need it, or in the outcomes on that daily, those daily moments as well, just to be able to steer us as clinicians to focus on the resident and make that first point. And also, that's probably one of the findings and the key pieces that came out of the Royal Commission as well, is that about having that real patient-centeredness or resident-centered care, and being able to evidence that and document that and show and demonstrate how aged care homes are fulfilling that and putting the resident at the center of their care.
Absolutely. And at the end of the day, we all know that when we get to that point where we are needing palliative care, of course, we want to have a say, and we want to be able to express the things that are worrying us and discuss that with the clinician. And that's what that tool is. It enables communication.
100%. So I know that, and this again is part of my learning as well in finding my feet in the role as improvement facilitator, is about how to teach the SAS to someone, how to teach to other nurses and care workers how to do and use this tool. And I know that one of our comments that we say is that sometimes it's one of the most difficult tools to teach other nurses, because we have to do some rewiring about how we think about that. So do you want to speak to that and what your experience has been teaching other nurses about how to think slightly differently about speaking to someone and using the SAS?
Yeah, absolutely. So I think with the SAS, I mean, it is set out like a list, like a checklist. And I think the most important thing we try to convey when we're teaching or sort of modeling the use of the tool correctly is, do not treat it like a checklist, because if you go and treat it like a checklist when you're talking to a resident, their responses are just going to be that of a checklist. Like, we really need to use the SAS as it should be used, and to get the information we're hoping to get from residents, which is what's going on in their head and what's worrying them. We need to have a conversation with them and weave those questions about those symptoms and problems into the conversation. So a good example would be, if I were to go into a resident and treat it like a checklist, I would be like, oh, hello, Mrs. Jones, I just need to get you to answer these questions. Can you give me a 0 to 10 score on your pain? Great. On your bowels? on your sleeping. You can see already this is not going to be conducive to any sort of accurate information, and it's certainly not going to be conducive to the resident feeling that they have a voice. So we say, go into the resident, who you know, because you see these residents, you know, daily, and say, hi, Mrs. Jones, how are you going? And you know, how are you going with that pain? You know, I know you had a bit of pain in your back, and you know, also I read in the notes in your knees. How is that now? And start the conversation, and always make sure you get away from severity and get onto distress.
I was about to say, because this is what we're measuring. We're trying to capture how distressed someone is. We want to be able to differentiate in our own minds the difference between the severity of someone's symptom and how distressed someone is about that particular symptom. And sometimes I think that can be really difficult for, like I said, the wiring in our nurse brains to be able to tell the difference. We have to consciously stop ourselves and think, are we defaulting to talking about someone's severity, when really what this is trying to tease out is how distressed someone is and how they actually feel, which can sometimes go against what we think clinically is going on for that person.
And if you keep a few key phrases in your mind when you're asking them, that will help you, you know, record accurately distress and not severity. So we tend to suggest you say things like, you know, oh, is that bothering you? How much is it bothering you? Or is it worrying you? Or does it upset you? And that way we can sort of get the resident focused through that lens, and that is something that they relate to more in any event. You know, if you say to someone, you know, oh, I know that your sleep hasn't been good because I can see on the nodes. Does that worry you? Does it bother you? Do you lie there worrying about that? Or, you know, and not also by talking about it in that manner, you open up a conversation, and when you open up a conversation, the residents feel like they have permission to tell you because you're actually asking the questions, and then they feel validated in their concerns because you're actually listening to them.
Yeah, so, and I think it's also the awareness that we are the gatekeepers and the key to having that conversation, because often we talk to people and we kind of talk without thinking about what we're talking about or how we're doing it, whereas we need to almost, you know, create that pause in ourselves to realize what we're talking about, what this means to someone, and being able to be cognizant and conscious of what we're asking and how we're asking it. Because, you know, we are trying to create an environment and focus, like you said, focus is a really good word, because you are trying to focus that resident to support them, and then to be able to create that conversation and that environment for them to open up, to trust you, and to feel valued for what they think, not just, you know, feeling like they should tell the nurse what they think the nurse wants to hear. It's about, you know, creating that environment and that conversation.
That's right. And I think the other thing with the SAS tool is that it's not a difficult tool. So like Caitlin said, we need to just always remember we're asking about the residents' distress, not severity, and it's what they think, not what we think. But once you've done it a few times and you do it in this sort of way where you weave into a conversation, it's actually a very, very simple tool to use. Like all of our
on that, Nat, I might just share, and we can talk to that about what the tool actually looks like and go through the symptoms. So bear with me for a moment. I'm just going to share this, and then we can talk about, there we go. So you can see there the distress scale from 0 to 10, and we've done that deliberately in those colors. Nat, do you want to talk about it, maybe just touch on what the colors mean as well, and how they work with you know, what we have in terms of our guide, clinical guide?
There's nothing too scientific about the colors. I think, you know, green is go, green is good. You know, think of a traffic light, you know, the yellow and the amber, it's like, oh, hang on a minute, caution, like what is happening here? There's something going on, you know, they're telling us that something isn't right. And then of course, moving up to the red, it's like, this is urgent. This is something which is causing them huge amounts of distress. And as such, we need to be responding to this immediately.
And I suppose I'm just referencing, we do have a clinical guide that helps, particularly when we're teaching care workers how to use this tool, how quickly they need to respond or sort of pass that information up to a registered nurse, and how quickly they need to act on that. So obviously
that's our escalation, our escalation scale for care staff.
So going through the symptoms here, and I know a bit of history, and Nat can probably speak to the history slightly more than what I can around the SAS, is that it is a tool that's been around for a while, that PCOC has used for a while as well. But I think originally it did come from the cancer oncology space, didn't it?
Yes.
Yep. Which is why some of the symptoms here at times, and I often say as well, they look very cancer focused maybe, or if you're a clinician used to working in oncology, you know, these are very common symptoms that you see in oncology. These symptoms are not necessarily the same symptoms. Some of them are, but they're not necessarily the same symptoms that we see in the aged care space.
But they are the 7 symptoms, though. They are universal in how they relate to people approaching end of life. So, it is, it's very relevant to use for any patient, whether it be patient or resident, that are receiving palliative care.
Well, that's like comorbidities are the normal now. Like there's another part of what we collect in terms of our diagnostic clusters in PACOP around, you know, how many different diagnoses or comorbidities does someone living in an aged care home have? And quite often there's more than one, and there's often more than 2, and sometimes more than 3 and 4. So all of the complexity that comes with that is going to give a myriad of different symptoms as well at any given time. Do we want to talk about and touch on the other symptoms, Nat, as well?
Yeah, we try to keep this simple, really, because other really is anything at all that is worrying them that isn't already specified as a symptom. So, I mean, we can give you examples of other, but really it's as simple as that, anything that doesn't fit into these. So, I mean, it could be, for instance, an itch. You know, it could be anxiety about their diagnosis, about their family situation, about their children. It could be anything at all, really, that is worrying them, because, you know, as we talked about before, this is all about the resident. This is their life, and this is actually their death that they're approaching. So we really want to find out what's going on in their head. Like I said, if during that conversation anything else comes up and it is actually causing them distress, then we rate it. Then we pop it in other, and we give it the appropriate score on the 0 to 10 scale. But of course, we do say, if you are rating anything in other, make sure you put a corresponding note in your progress notes as to what it is that you're rated. Of course, because, you know, then when the next shift or the next clinician comes along, they know what it is. You know, they'll see if they see a 10 in other and there's no corresponding notes, they're like, oh, I don't know what I'm supposed to do here. But, you know, of course, this is just nursing 101. If you're going to rate something, then of course you need to clarify what it is and what you're going to do about it.
Actually, it was interesting, the last workshop that I did, I was speaking about these symptoms and the other, and I asked the group, you know, if you were to put down other, if you think of your residents or the residents that you can think of off the top of your head, what would be something else that you can think of in terms of a symptom that they buzz you for, that they need help with, and how do you think they feel about that? And I had one person in the workshop tell me, you know, and you know, the number one thing that this particular resident that she was thinking of, that she was distressed by, not severity but distressed. I said, what's the number one thing that you think that resident is distressed by? And she said her mobility. She is that frustrated. The one thing that distresses her most is her mobility, and that she can't move and her body doesn't work the same as it used to. But also the second symptom or thing was her incontinence. Both of those things, and, you know, despite having underlying pain perhaps, or bowel problems, or just other things that are going on in terms of this lady's health, she said, if I put myself in the shoes of that resident, I suspect the 2 things that she would say bother her the most is the fact that her mobility isn't what it used to be, and that she's incontinent and has to use incontinence aids.
And that's a great segue into, Caitlin, into a hugely important point we need to make about the SAS, is that the SAS, what we as clinicians think is important is totally irrelevant when it comes to the SAS. You know, we're not saying they're not going to be addressed, because all of the other assessment tools in the PACOP collections are clinician rated, but this is all about what the resident thinks. So if the resident is telling us, for instance, that they have a 9 out of 10 pain score, that in relation to distress, and clinically we're thinking, oh, I wouldn't have thought that, I know that they've had this amount of medication, they appear to be moving freely. That's all irrelevant for the purpose of rating this tool. If a resident thinks that it is it's distressing them, that's what we record. And the beauty of that is then we can use that with our own clinical assessment and go, okay, something's going on here because there's a bit of a mismatch. So how can I explore that with the resident to find out why their distress level is so high in relation to this symptom, and therefore you can address it. Whereas without the SAS, we wouldn't have had that opportunity to know that the resident was thinking in their head that their pain distress level was so high. And we wouldn't be addressing it because from a clinical point of view, we would think that their pain was very well managed. So it's just, and another great example, I love to use this example, Kate, and I know we're running out of time, but I'm just going to be quick because this is something that I think is really quite relevant. As clinicians, like if we say to a resident, how is your fatigue? Have you got any energy? And they're like, that, it really, really, really bothers me. It's the thing that upsets me the most. I have no energy by early afternoon. I'm too tired to basically even read a book. As a caring clinician, once upon a time, I would have said, oh, don't worry about it. You don't have to do anything. You sit back, you relax, you watch TV, we'll do everything for you. But I'm not hearing what the resident's telling me. The resident's telling me that this is hugely distressing for them. And this is actually extremely common, that there's high distress levels in relation to fatigue. And by me actually listening to them, by virtue of using this SAS tool, I can explore that further. And I can find out that through the resident's eyes, fatigue is such a huge thing for them because they know that their days are numbered and they want to spend all the time they can with their family. And yet by the time their grandchildren come in the afternoon, they have no energy left to even have a conversation with them. So by getting that information from the resident, number one, we're validating their feelings because we're inviting them and we're listening to them tell us about it. Then we can put something into place. We can say, okay, well, how about we don't have your shower then until the evenings after your grandkids or whatever it is, So it's huge and hugely important that we listen to what's bothering them and take off our clinical hat for the purpose of this assessment about what we think is important.
Can we spend a few minutes just talking about, because I know this question often comes up, how do we manage people who are living with dementia or who can't respond? Like we talk about having proxies and being able to proxy score for different people. But do you want to speak to that a little bit, but also address those that have mild dementia that you can still have a conversation with versus those with advanced dementia who are no longer verbal?
Right. So the SAS tool has the opportunity to be proxy rated. So obviously gold standard by virtue of the actual tool itself is rated by the resident or the patient if you're in an aged care setting. But if for whatever reason, due to cognition, we're talking about here, they're not able to communicate with you in a conversation, you have the ability to rate it as a clinician by proxy. Now, the proxy rating of the SAS can be done by a healthcare professional like a nurse or any of the allied health team, or it can be done by the family of the resident. It can be done by the care staff if they're collecting the SAS scores in the outcomes collection. And if you're rating as a proxy, we ask you to view these symptoms as best you can through the resident's eyes. And we have got a guide where we have listed if a resident is unable to communicate with you and they have mild distress or moderate distress or severe distress in relation to this particular symptom, these are the things you sort of might be seeing from the resident. So we have that guide on the back of the SAS daily care by the care staff use and the outcomes thing. And we ask when you rate it as a proxy, then of course you have to mark down that it was rated by proxy because that's hugely important for us to be able to provide that feedback for you when it comes time for you to get your reports. But interestingly, and I think this is something that is really good to know, is that in the past there has been in PCOC, there has been an inter-rater reliability study done on...
I was about to say, how do you manage bias? Like how do you manage when a nurse or a family member is trying to proxy in for a resident who can't speak?
So I mean, you have to do the best you can do, but it is very good to know when you're rating it as a proxy vote that this study that I was talking about has shown that clinical staff, when they're rating as a proxy for a resident, tend to underrate the scores in comparison to what the resident would say themselves, and that family tend to overrate.
Yeah.
So taking into account what Caitlin says with your bias, if you're aware of that, that can help you when you're rating as a proxy. But also when you think about it, it does sort of make sense, because the family would rate distress scores higher because they're so worried about their family member and they feel powerless. So they give it a higher score, thinking that this will make things actioned sooner. Whereas a clinician who is working there and is sort of knows what's going on with the resident and feels comfortable with that the care that they're getting is good, you've got good medical insight and all that, we will tend to underrate it because think, oh yeah, we're onto that. So it's just good. I mean, you can't fix the bias 100%, but by being aware of it, you can certainly make it less.
It comes back down to that awareness and being cognizant of that, and that you could sway either way, or that there is potentially a sway. An interesting story on that, the last workshop I did was around a group of people who were rating someone's or proxying in for someone's distress around their bowels. The resident had constant diarrhea, changing her incontinence aid every 2 hours, and they didn't rate that as a high distress. They put 0, no distress from that. And I paused them, I stopped them, I went, do you think that if that resident could talk to you, do you think that she would be distressed by that? I said, we're not rating severity. Yes, she's got regular bowels and that's great, but she has, very loose stools, she's constantly being changed. I'm like, do you think if she could talk to you now, would she be distressed by that? And that was a really interesting point, because it made them stop and think that, yes, she hasn't got clinical bowel problems, but is that level of, care around her bowels, is that possibly, if she could speak back to you, that would probably be distressing for her. So that was really an interesting social experiment, or just discussion to have with those clinicians.
It's that ongoing discussion. Exactly. Yeah. And it's just within your own team, it's just that ongoing discussion. Like sometimes you need to go, hang on a minute, it's not severity, it's distress. You need to just that constant reminder, because we're so used to rating severity of symptoms as clinicians. But yeah, it's just always bringing back that focus.
And also, I think we also have to be cognizant about the time of day and after what actions we ask these around SAS, because obviously if someone is transferred or hasn't had their analgesics yet, their distress around their pain is probably going to be a lot higher. So you have to work out and be aware of that as well. But is this actually an accurate representation of distress over the last sort of 24 hours about that symptom? I'm just cognizant of time, and I know we've still got a few live attendees there. If anyone has any questions, feel free to put in the chat or the Q&A. Apologies, I didn't encourage you all to do that at the beginning of the session, but we're more than happy to take some live questions.
I think another thing we can mention here is we have those visual aids. So we have we have the large SAS rulers with the smiley faces on, which can help. Some people find that very helpful for to show residents and say, whereabouts on here, how much is it bothering you? Show me which sort of face. We have some little lanyard cards which are designed. Oh, we've got a question.
Yes, I'm just going to put Helen. I'm just going to put you. Do you want to unmute and you can ask us the question that you wanted to ask?
Do we have to unmute Helen? Might have to be Zoe. Can you unmute Helen?
Oh, we're trying to unmute Helen.
But yeah, we have a whole range of resources and lanyards, rulers, information sheets, resource sheets. If you need anything like that, just hit us up. They're there for you. They're there to be an aid, both for yourselves and for the residents. So let us know and we'll certainly help you out there.
Okay, apologies, Helen, we couldn't hear you, but if you want to pop a question or type in the chat. Otherwise, we can email out some links following this session today, and maybe even reference to that study, Nat, if we can, for people that are interested around the interoperability. But our next morning tea talk is on the 31st of August, which will be another Thursday, and we will be going through the phase tool. So stay tuned. please register for that if you are interested. If you can't make it on the day, that's completely fine. Please register anyway, and we can send you the link and send you
And
any
all of these
resources.
recordings are up on our YouTube channel.
Yeah.
So for this talk and all our previous MTT talks, so you can have a look at them whenever suits you, or let your staff know, or
Wonderful.
just shoot us a question. Yeah.
Okay, well, thank you very much, everyone. Have a lovely day and lovely end to the week. Tomorrow is Friday, and take care. We'll see you all again soon.
Okay.
Bye.
Thanks, everyone. Bye.